Good evening, everyone. Very nice to be here. Welcome to the Shoreham Wordfest. I'm Alastair McLellan. I'm the editor of something called the Health Service Journal, which very few of you will have heard of, which is fine. Suffice to say that since 1892 we have reported on the nation's health services, the birth of the NHS, etc. And I've been editor for about 10% of the time since 1892. So we've got a really fascinating subject for discussion tonight, and good hour and a half to get really stuck into it. The NHS is the nation's most beloved institution. It scores much higher than any of the royal family, army, the BBC, the church, you name it, it's way ahead. I have said in the past that it's perhaps the only thing, the one remaining thing which unites the country in its support. And of course it has just been through its most trying time, global pandemic. I've been through. Of course, COVID is still with us, very much so, and we're in the middle of, at the start of yet another wave, the fourth COVID wave of 2002. More people have been admitted to NHS hospitals with a positive COVID diagnosis in 2022 than in 2021 or 2020. So we are COVID is still very much with us. And as we will explore over the next hour and a half, I don't think the service has ever been in such a fragile and dangerous state as it is at the moment. And we will explore what might be why that is and what might be able to do it, what might be able to be done about it. So, without further ado, let me introduce our two speakers today. We're going to hear from them very briefly. I might ask some questions. Then we'll open it out and we'll have a debate amongst us all. So, on my far left, just geographically, not that I know politically, we have Dame Marianne Griffiths. Dame Marianne will be somebody who is very familiar to people in this part of the world. She ran Great Western and then the newly merged trust with Brighton for 14 years as chief executive. What you may not know was how in high regard she was held by other chief executives in the NHS. Each year HSJ would conduct a survey, a poll amongst health service leaders to see who was the most highly regarded hospital chief executive in the country. Marianne was never out of the top 5, and she was number 1 on at least 2 occasions and number 2 on another occasion. So she really was, as far as her peers were concerned, a really excellent chief executive. And in the centre here, both geographically and pretty politically, we have Jeremy Hunt. Again, somebody who really needs no introduction. Perhaps the only unusual thing I can say about it is probably the first time you've found yourself on a bill with Attila the stockbroker, who I see was here early on. So Jeremy Hunt, of course, was Secretary of State for Health for about 70 years. No, it wasn't that long. Jeremy has run England's health services for longer than any other individual. Going back at least to the birth of HSJ in 1892 and probably beforehand. As Secretary of State for Health, he also, of course, served as Foreign Secretary, turned down the job of Defence Secretary, ran twice to be Prime Minister, and has just completed the London Marathon. So, I'm really looking forward to this evening. It's going to be a really fascinating hour and about 20 minutes now. But let's hand over to Marianne, and
Thank you.
Over to you, Marianne.
So, good evening, everybody, and I'm really delighted to be here. I live in West Sussex. I've grown up here, I have to say, and I've spent most of my NHS senior life in the area and in the hospitals. And it's been probably one of the biggest privileges of my life to serve our patients here. So really delighted. What I've been asked to do is to just reflect on a number of things. And I think Ros asked me to kind of give a prescription for how we might improve the NHS in the future. And what I'm going to do is talk from a very personal perspective. I do not represent any organisation at the moment. I retired in March, the end of March this year, having spent 14 years as chief exec, and the last 2 years really in the pandemic. And there are three things that have really shaped my thinking and have informed what I'm going to say tonight. One of those is to really try and look at the NHS, and sometimes that's difficult when you're in the heat of it, through a patient lens. So, what are patients experiencing at the moment? The second is genuinely my organisational experience as a chief executive for a long time, and also kind of what I've really observed in the pandemic, which I think, from my perspective, has amplified probably fragilities that were already there, but made them bigger and actually more of a challenge to deal with. So that's where I'm coming from. I'm going to start with one of the biggest challenges, and it's not a new challenge. It's always been a challenge in the NHS, and that is workforce. And one of the things, again, and I'm sure Jeremy will want to talk about that, is that, there's a big issue, and I think, again, the concern was particularly amplified during the pandemic, is do we have sufficiency of staff for a growing need and demand for health services? And when you look at figures around the country and you look at demographic issues, i.e. people retiring, you kind of know you've got a problem anyway. So I think what happened, obviously, in the pandemic is that those that you did have, of course, were affected themselves by COVID, and it did put an enormous stress on any provider-led service in the arena. So there's one bit of the workforce, which I know is not new as a problem. It's the sufficiency. How do we absolutely plan to get the right numbers in the right place, doing the right things, so that patients get the safe and effective services they need? But there's a second issue, which I believe is equally as important. And if I'm being honest, was the issue I was dealing with in the last year of my CEO experience. And that is, actually, retention has become a significant issue. So you may look at your vacancies, but if you have got vacancies, the thing you need to focus on is how do you retain your staff in those troubled times? And I think it's quite a complex issue. I don't think, one needs a retention strategy. Of course you do. But it's not a generic thing. There are different complexities, different variables that affect depend on your economic situation, your demography and the area that you live. But again, it's been really affected, I think, by the post-pandemic impact, and although we're not quite post-pandemic yet. So things like, some things, for example, around, a bit of low morale in the service for those people who've just experienced the last 2 years, relentless pressure of people that have worked there, and it has been really relentless and difficult at times, and obviously people want to do their best. I think there are issues around flexibility of staff and how you can deploy staff when you need them and where you need them most. And of course, there's a sense of not feeling valued in some instances. And there are issues, for example, like changes in pensions and all sorts of issues, whether it's pay, that do have an impact on staff and how they feel moving forward. And I think kind of what's happened a little bit, I feel, because of the pressures, is that the sense of belonging has slightly diminished in our organisations. And whilst it's absolutely true about the morale going down, it's gone down everywhere. And I've been working up in Bristol. I'm working with 2 organisations up there at the moment, and they're facing exactly the same challenges around morale and retaining their workforce. And their turnover figures, again, are very worrying. So it is a big issue. And the point is, it's not a new issue, and I'm sure Jeremy has, and I know he has, referred to it in his book. But I think it's not what the problem is, because I think we kind of know that. It's how do we resolve it? Because that's been, I think, the issue over the last number of years, is what do you do that actually addresses some of the what the problem is, and the how, I think, is important. And I think, some of these things really do require quite an intelligent approach, and I don't think there is a one-size-fits-all. I've been kind of reflecting, because there have been workforce strategies forever since I've been in the NHS, if I'm being really honest. And my kind of observations and reflections about why do they not seem to have worked, or worked partly, or whatever it is. And I guess really, if I'm being honest, my kind of take would be that the workforce strategies have been very generic, quite centralist, often without really, I think, understanding of local situations, and perhaps the power to make the changes has not sat where the power needs to sit. So there's something for me about where is the best location that you actually do really fantastic integrated strategy for health, and indeed social care for that matter. And my kind of take would be that it does need to be at either place or system level. But I think what would be useful is for some of the resources that do sit centrally to come and actually help systems to do that with the skills that they need. It's not just getting another HR director, it's getting somebody who actually knows
Marianne,
how
I'll
to
just
work
interrupt to translate. System, county, for place, town.
Thank you for that. So there's just about making it smaller, more local and understanding. I'll just give you a quick story that demonstrates this. We've had, you'll have seen this, we want 6,000 more nurses. And sometimes you're waiting for the answer to magically seep through to you. One of the things I've really learned is that you take control of your own destiny. And one of the things we did do, which I'm really proud of, is that we worked with our local university, which was Chichester, and we thought this is what we need to do. But to retain nurses, you probably want to have a bit more who want to live in the area, maybe are more mature. And actually what we did is really, really develop a whole framework and a whole kind of specification for how we would deliver that within our county. And we did it. And we had an opening of the School of Nursing in Chichester a couple of weeks ago. And I really do think it's those sorts of things that will make the difference locally, and will retain staff as we move forward. So there's something that needs to happen around that is different to what we've done before. The second big issue, which really causes stress in a provider, hospital, and indeed primary care or any other provision of services, is kind of what we call, the demand and capacity gap. So the demand for services is growing, which it is, because our population is growing older, and with that sometimes comes more usage of services. There's been an absolutely huge, significant impact with the pandemic, because for first phases we couldn't do operations that you'd normally do, so we've seen our waiting lists grow exponentially in some cases, and that's both for cancer and for planned care, so operations like your hip replacement, your cataracts, all those sorts of things. The fragilities around, were there enough resources anyway, whether that's workforce or beds or estates to deal with this, have again become amplified during this point. And the reality is, too, where there are fragilities, is what I'd call in the organisational handoff. So, you have a patient, again, using the lens of patient, comes in, needs some support, and I think people will recognise, you can ring up primary care, you have to listen for 5 or 6 minutes to see why you shouldn't come there first. And then you are handed off to somebody else who then will tell you to go back there or something. It's not easy. It's frustrating, actually, for anybody who's trying to enter the system. Once you're in this system, I think you do, on the whole, get really good care. But accessing it is a nightmare for people. And I think that's still a real issue for us. And I think we need to do something more around that. And I think the other issue for me, and this is why waiting times do matter, I think sometimes our patients are hugely forgiving about having to wait, but there is a point in waiting where there's harm, where there can be potential harm. And that's when it does become an issue, whether you're waiting for a cancer treatment or you're in pain, waiting for an intervention that will remove that pain for you. And again, if we look at what the problem is, how do we resolve it? And there are some big issues and big conversations, I believe, that need to be had. One is, and I'll mention this, is how do we explore and really accelerate models of integration? And what I mean about that is how do you, we don't even have a single, for example, IT system for health in the whole country that actually works seamlessly. But how do we actually really get primary care, secondary care, tertiary care, community care really working together? And there are models that exist, places, and some of them are being trialled, but there still seems to be a slow pace in really driving some of that forward. So that's really about, I think we need to really focus some of our resources on that. There really are issues, I think, and I was chatting to Alastair earlier, and again, I say this with the greatest respect to individual GPs, but primary care was formed with a GMS contract, which is the type of contract they have, in 1948. I think it may be time to modernise this. And my worry is that we tinker around the edges of the contract to try and get a bit more flexibility or a bit of this or a bit of that. And maybe we kind of need a big bang, different approach. There are different approaches, and this is where you need to go see, sometimes abroad. I've certainly visited Virginia Mason, who actually manage integrated primary care as well. There are brilliant Miami models in Florida and all around, actually, the world. And I just wonder if there needs to be a step change in a new model of primary care and integration around that. So that's a biggie that we need to consider. The second one, which has been, again, really amplified in terms of its significance in the pandemic, is the role of social care and out-of-hospital care when you're talking about releasing, for example, beds and resources to do the cancer treatments, to do the urgent care treatments, and to do the planned care treatments. And if I just give you a few figures on that, normally, and you will have heard the term, they change routinely, delayed discharges, medically ready for discharge, all of that. What we're talking about is people who really are fit to go home, but may need some support, but have no support in getting out of hospital. And that's not a good thing, because what happens when people are in hospital too long is they deteriorate, they decompensate, is the word that they use, and actually their kind of ability to recover is reduced every week that they're in hospital, every day that they're in hospital. But the figures that we were normally working with, certainly in Western, would have been about 3% delayed discharges. In the pandemic and post the pandemic, those figures went up to 25, 30% and are around the 20%. Now, what that means is that a fifth or even up to a quarter of your bed base is now taken out. You can't use it for doing the cancer treatments and doing the other treatments that actually your population needs and patient needs. And I think that's a real issue. And I think it's not just the big issues have been around funding. Have we just reaped, the lack of funding in social care? And that is an issue. But I know during the pandemic, we did have more money to put into social care. It was still difficult to get the traction on actually getting people out of hospital. And I do wonder again, it's not just the finances which are really real around this, but I wonder, where is social care or adult social care very much in particular best cited? So maybe there's actually a discussion that needs to be had about that as well. And again, of course, we talk about digital. What the pandemic did teach us positively is, my goodness me, did we learn how to do things differently very fast, actually, in terms of whether it's running outpatients or doing assessments or doing all sorts of things. We used information technology in a way that we'd never used it before. And it shows you what can happen. And I really am a huge supporter of our digital transformation. But again, I wonder, how do we put the pace and effort into making that very real for the front line and, of course, for patients, including giving them some power over their own treatments digitally as well. So then if I kind of move on to that, finances. You heard Alastair mention finances. And it's really interesting. Finance has always been challenging in the NHS. And, it's a publicly funded service. Get that completely. but I'm sure you've been listening to the radio and watching the TV, and just thinking about how actually are we going to at least secure the existing funding we have plus more. And again, there are, if inflation isn't covered, that's a huge burden again on the health service, or some other parts of the service aren't modernised. So there really is an issue. I would say, however, that I'm also of the opinion too that in my kind of last 14 years, we've always managed our budget, and I think by doing the right thing in the right way, I think that does help you actually achieve that, because you're doing it more effectively. But there are still issues about, as I say, inflation, the huge waiting lists we now need to address, and actually how do we secure the resources to do that. But I think the biggest kind of financial issue for me is capital. It's the one thing that is quite short term at the moment. And if you look at the estate in many hospitals, for them to really modernise and actually be very effective in terms of their pathways, they do probably need an upgrade in some of the estate's work that happens. And I think, again, a longer term strategy for that would be really important in moving that forward. So there's, a number of things I think we could do, at least secure what we need to, recognising the public purse is paying for it, but definitely have a longer-term strategic planning for capital. There's just a couple of more things I want to make before I quieten down. I could talk about this forever. It's my favourite topic. One of the other things I do want to mention also, though, is what I would call the structural management of the NHS. And again, this is very much going back to my CEO role over the years. And I wonder again, given kind of where we're at, a seminal moment in the life of the NHS post-pandemic, hopefully, if we need to really look and review the structural management of the NHS. And the reason I say that is it still feels to somebody like me, and I know colleagues who share my view, that there are too many layers in the NHS, and that the power for change really does rest with the front line. And how do you actually put the resources more in the front line to make changes in hospitals, in primary care, etc. And at the moment we've got regions, and we've got integrated care systems that have been put in. And if I'm honest, there has been, I think, some duplication or fighting for a little bit of the same space. And actually, I'm asked for the same piece of information. I was asked for the same piece of information by 2 different people in 5 different ways, needing it yesterday. And you kind of think something needs to be a little bit more efficient around some of this. So there's definitely something I think we need to do around that. And my real perspective on this, because I feel so passionate about continuous improvement and learning and doing things the right way, really, sustainable way, is I do think that there needs to be more focus on the problem solving rather than the constant disappointment that you have a problem. And I would kind of, really classify that as, it's the questions that we should be asking is what is the problem and how can we help you, rather than, why do you have a problem and who's caused it? So there's something about shifting a little bit of that, which I think is not quite where it needs to be as well. And lastly, I would just say there's something for me as well about a consistency of priorities. And again, to be fair, we've had a bit of a roller coaster in after Jeremy left, in terms of 4, I think now, Secretaries of State since you were there, Jeremy, in pretty fast succession. And and there's always slightly different priorities. And sometimes you just need to do the inch wide and a mile deep, not scattergun, a mile wide and an inch deep. And having that stability, I think, would help too. And last but not least, something that is so dear to my heart. And if we don't get this right, everything else I've said in terms of our problem-solving strategies, etc., will not work. And that, for me, is the whole issue of leadership and culture. And I just really do want to say something, because I believe it in my heart, that the people who work in the NHS are absolutely brilliant. And never was that so live and visible to me than in the pandemic. And I think of, the noble deeds that people did every day, and they always have done. And the kind of, honestly, moving stories I've heard of compassion, kindness, effort, it's just been extraordinary. And that is why the NHS is loved, because there are amazing people who do amazing things every day. I believe we have to build on that and keep the narrative and lexicon, really, of health positive. And sometimes it feels as though it's gone from the clapping for the pandemic to why is the waiting list so high. I really understand the concern, and from a patient perspective get that. But I think we need to be improvement focused and encourage people to even give more than they do and lead them up the hill for this. And I think that's really important. And the other couple of points I'd make, and again, I think you do pick this up in your book, Jeremy, is the more experienced I became, so the longer I became a chief executive, genuinely, the more obvious the importance of culture became. And I really mean that. And it's culture at all levels. It's clinical culture, it's organisational culture, it's culture centrally. It's about, is your culture genuinely focused on the needs of the patient? Is everything you do about relentless improvement for them? Is it about, learning, so you will get things wrong? What's your learning culture about really trying to improve things for the future? And of course, you have a leadership culture. What is that? Well, how authentic is that in organisations, in the whole hierarchy of the NHS? And again, I just think the pandemic did highlight some fragilities around that. And I do believe, genuinely, people get that this is all important and culture and leadership are important. Positive leadership is important. But what I would say is sometimes, and I think we need to acknowledge, that the behaviours that support that seem a little bit slower and need to catch up with the rhetoric of some of this. And I think where we have problems in the NHS, systemic problems, it's often really around those sorts of issues, I have to say. And again, I think we're at a point as well where it's important to demonstrate some kindness and compassionate leadership for our staff. They do need to see a light out of the pandemic. And I kind of leave you really with a point that is very dear to me, is that I think, again, we as an NHS and the whole NHS leadership, whether it's political leadership or managerial leadership, do need to pursue this authentic, positive and inclusive leadership because it is the bed for real improvement and sustainability moving forward. It's the only thing that will sustain, actually. And I think that's what our staff deserve and what our patients deserve in terms of bringing that forward. So I'm going to stop there. Thank you very much.
Thank you. Right, we'll come to Jeremy in a very brief moment, but I just wanted to ask one question of you, Marianne, which is, you talked of the importance of positivity and, improvement, and those are very important, and I'm sure we'll explore them further. But in the next 2 years or so, 18 months, 2 years, people doing the kind of job that you used to do are going to have to make some really hard decisions about stopping doing things, either stopping providing something that they're doing now, or not going to do something that they had planned to do. I am very sure that chief executives across the country will seek out your opinion. What advice do you give them when they ask you, what should I stop? Where should I cut? How do I cope with that? As you all know, perhaps some of you know, all the usual suspects. The training budget's gone. The comms budget's gone. All the obvious low-hanging stuff is gone. We're into the bone now. How does a chief executive deal with those kind of really difficult decisions?
I don't think any of those issues are new. I do think, again, the size of the problem may be different now. But one of the things that I've always believed, and I do believe this, is you need to have genuine reality glasses on. So that's not being Pollyannish about the problems that you're facing. But your role as leader is also to prioritise, which it is. And I guess we all do that in all of our daily work. And my kind of bit is, if you do that really well and with people, you actually get the followership that you need to do. And I know I use this term an inch wide and a mile deep, but it's been an approach that we certainly adopted in our hospitals.
So, Marianne, let me just press you on a little bit more specifics. You said it's about priorities.
Yeah.
What would be your priorities, or what advice would you give to a chief executive about their priorities? If I look across the NHS, as you'll know, I see huge waiting lists in every area. I see quality problems with, healthcare acquired infections, something like that. Which things would you prioritise, and which things would you say they're important, but we can't give them the same amount of attention?
Right. So the way of doing that, and I am working in actual fact with organisations who are going through that process at the moment, is that you may say the waiting list is a major issue. Of course it is. But you've also got to look at within that problem or the stated waiting list, what one or two things could you do in a year, or three things maybe, that would turn the dial to improve that the most in that year. And my bit about that is you need to understand the contributors to your problem and where they are. And I think you've got to agree that you can't scatterguns, you can't treat every single thing in it, but that you would focus on one or two or three things. The same with finances. So again, I'm going to be very specific about that. Again, if you looked at your contributors to an overspend or your financial challenges, 70% of your budget is going to be on people. If you're really looking at that and what's happened in the pandemic, what most hospitals are facing is they're not getting the same activity for the same pound spent pre-pandemic. So again, if you really analyse that bit, again, positively, if you improved productivity in one or two specialties or three specialties in a year, where does that take you to do it? So the point is, you can't always cure every single problem. Your job is to select the ones that have the biggest impact and actually work with that. So my advice is the same, Alastair. It's just about being really focused on the one or two in all of those big headline things that you'd work on. And the third one, because I do believe this is really important, is the cultural one. And that's everyone's business, and everyone has to put that as a priority. And about engaging, seeking followership, being inclusive with your staff in solving those problems. And, a top-down approach does not do that in an effective way. It does need to be with people. So they would be my 3 top tips.
Thank you very much. Right. I remember once talking to one of Jeremy's special advisors, which they said, and I paraphrase, Jeremy's really irritating to work with because he always has the best ideas and he's always able to express them better than anyone else. And so sometimes I wonder what I'm doing. And Jeremy is one of those irritating, multi-talented people. And one of his talents is that he writes well. And he's written a book. Rare unsigned copies still available on the table out there. Get them while you can is my advice. But I'm sure Jeremy, it's a very good book. It is a very good book. Even Rachel Oxford said it was a very good book. Jeremy, why don't you tell us about it?
Thank you, Alastair. Well, good evening, and thank you, Ros, for inviting me to WordFest. And let me just start by saying that I am really honoured to be sitting here with this incredible panel. Marianne was one of the chief executives that I admired the most. I'll tell you the story of how I came to admire her, because I didn't know her when I became Health Secretary, and Alastair is, I think, probably the wisest journalist covering the health space over many years, and he is the sort of collective memory of Christmases past. He will tell you what Ken Clarke failed to do as Health Secretary and what Alan Milburn got right and what Andrew Lansley got wrong, and he's a wise voice. It's an honour, but it's quite an emotionally challenging thing to be Health Secretary, as I'm sure it is to run a big hospital. And so I had 3 lockdowns in which to sit down and really think, what on earth do I wish I'd known at the start that I know now? And that was the result. Really, was this book called Zero, which is a about one particular challenge that obsessed me for my whole time as Health Secretary, which is how to reduce the amount of avoidable harm and death. So that's why I call it zero. Could we get down to zero avoidable harm and death? But in a way, it's also about how you change things in a huge organisation like the NHS. And it's a kind of manifesto for what we want to do if we want it to have the highest quality care anywhere in the world. And I thought in these introductory comments, I would just tell you how I came to write it, because I was actually Culture Secretary responsible for the London Olympics, and it was still the last week of the Paralympics when David Cameron asked me to be Health Secretary, and it was a total bolt from the blue, and it was an incredible shock. And if I'm honest now amongst friends, it was totally scary, because the NHS is huge, and I had no background knowledge of the NHS apart from being as a patient, but I've been pretty healthy, so I hadn't really had much interaction with the NHS. And then this wall of crises hit every health secretary. And in my case, the very first one to hit me was the scandal of what happened at Mid-Staffs, where between 400 and 1,200 people died, the most horrible deaths after being appallingly cared for. And it happened over 4 years. Then there was a public inquiry. And the public inquiry, the Francis report, was due to report just a few months after I'd become Health Secretary. So I started to go home and read these stories. And the head of the NHS, who I actually met for a cup of tea this afternoon, Sir David Nicholson, head of the NHS at the time, said to me, Jeremy, you just need to understand that in healthcare, we harm 10% of patients. And he said it in quite a matter-of-fact way. He was trying to be helpful, but he said, this is what happens in modern healthcare systems. And I said, well, what do you mean?
Not just in the UK.
No, absolutely not.
A global thing.
Absolutely. And I said, well, what do you mean by harm? And he said, well, it's just, when procedures aren't followed, things go wrong. It's not, that person dies because we didn't have a cure for that particular type of cancer. It is a mistake causing harm. So I then asked a question which I don't think previous health secretaries had asked, which is, well, how many people actually die as a result of this? And being the good old NHS, we have done endless academic research into all these issues, and there's a study by a couple of academics at the London School of Hygiene and Tropical Medicine, which says that 4% of hospital deaths have a 50% or more chance of being avoidable. So I then said, how many actual people is that? And it turns out that it's 150 a week in England, 150 preventable deaths a week. And I thought, I've never heard that before, and it feels like a bit of a scandal that we're just taking this for granted as kind of inevitable cost of doing business. And as Alastair pointed out, I didn't realise at the time this is a problem all over the world. And but I didn't firmly start on this journey in the health world, as Alastair and Marianne will know. We call this the patient safety agenda, how you reduce avoidable harm and death. But I didn't really start on the patient safety journey until something else happened. Again, just a few months after I became Health Secretary, something you might think is completely unrelated to my responsibilities. But as a Cabinet Minister, I was invited to Margaret Thatcher's funeral. And I remember sitting in the second row, this was in 2013, the spring of 2013, standing behind the former Prime Ministers, John Major, Gordon Brown, Tony Blair, singing I Vow to Thee, My Country, thinking this must be the most Tory moment in my entire life. And by the way, there's another fantastic Tory here, your brilliant local MP, Tim Lawson. So I was in this funeral, and I then heard the eulogy by the Bishop of London. And he described how Margaret Thatcher had personally replied to a letter that a 10-year-old boy had sent her when she was Prime Minister. And I sat there and I thought, I've been Health Secretary for nearly 6 months, and I don't think I've seen a single letter from a member of the public. And it turned out that I had an army of 150 officials whose job it was to shield me and the other ministers from what the public were actually saying about the health service. So I said, well, look, I would like to receive one of these letters every day as the first thing I do. I just want it sitting on my desk, and I'll do a personal reply to it, just to, start the day off. Anyway, the weeks went past and no letters materialised. And it turned out that they'd been having lots of Sir Humphrey-like meetings behind the scenes to try and work out how to dissuade the Secretary of State from this thoroughly dangerous idea. And I chased it, and eventually a letter came back saying, "Dear Mr. Hunt, I'm just writing to thank you for the fantastic care I've had from the NHS." And I said, no, that wasn't the letter I want. And then the first proper letter came, and it was they were all utterly harrowing. One of them was, one of the very first ones was of a father from Cumbria whose teenage daughter killed herself the day after she'd had an appointment with a mental health nurse who hadn't identified any serious risk. But there were lots and lots of stories like that. And I did a handwritten reply, and quite often I would actually invite in the families. Sometimes I would invite in the chief executive. There was one occasion when a gentleman wrote to me about how he'd gone to visit his father in hospital. His father had dementia, and he was lying naked on top of his bed with a catheter attached to his private parts in a public ward. And he complained, and he was brushed off by a nurse. And so he wrote afterwards to complain to the chief executive of the hospital. And so I wrote a letter of apology. And a couple of hours later, the very chief executive happened to come to my office to ask for some capital, Marianne. And I thought, is it the same hospital? And I'm afraid that gentleman had the most uncomfortable meeting of his entire life when I explained to him about the letter I'd received, but because he didn't even reply personally to that person who complained. He just got his secretary to PP a reply, and in fairness, he did personally go and visit the family after that. So I started meeting these families, and I thought, I need to tell some of these stories from a patient's perspective. And I started to find some real surprises. And the surprise I found was that there is an army of ethical doctors, nurses, chief executives who are every bit as troubled as I was about this issue. And actually, the first person I met who was like this was Professor Sir Bruce Keogh, who was medical director of the NHS at the time. And he said to me that he was a heart surgeon, and he said that one of his patients died after his operation, and he was very upset about it. And his colleagues all consoled him and said, "Bruce, he had a very bad heart, he was going to die anyway." And Bruce said, "Yes, but he wasn't going to die on Tuesday." And that's really the point, that you need a mentality where you're treating every single patient as if they are as precious as your own mother or father or son or daughter. And so I concluded some things. I did lots of things to improve patient safety. I had some battles which I really in a way regret happening, like the junior doctors' strike. But by the end of it, 3 million more patients were using good or outstanding hospitals. And I concluded a few things, which are really what I write about in the book. But the first is absolutely what Marianne says. We are terrible in modern healthcare systems at learning from mistakes. And when I went to visit Western Sussex or Worthing Hospital for the first time, I discovered a hospital which had the best learning culture of anywhere that I've been to in the NHS. An organisation just obsessed with what they could learn and how they could do things differently. But it's not like that. That was a culture that Marianne set right from the top. And, we didn't have a CQC regime giving ratings to all the hospitals until I arrived. And I instituted that because I said, we need to know which are the best hospitals and which are the worst ones. And the first two hospitals to get an outstanding rating weren't the famous London teaching hospitals, None of them got an outstanding, actually. It was 2 hospitals that, with the greatest of respect, no one had much heard of in the NHS. It was West Sussex and Salford Royal. And the interesting thing is that there was a pattern emerged, which is that the best hospitals, through this independent rating system, tended to be places with the most modest chief executives. And Marianne, I think, has a phrase about, what's your phrase about being a good listener? What do you always say? You need to spend all your time listening to your staff.
It's big eyes, big ears, small mouth.
It's a very, very good leadership philosophy. I don't think it would work in Westminster, but so that culture, having a learning culture, but at its most brutal level, if a child dies because of a mistake in a hospital, we make it absolutely impossible for doctors to be honest because they're frightened they'll be fired, or someone will come down on them like a ton of bricks, or they'll be hauled up in front of the General Medical Council, or they'll be sued. The second thing I learnt was really what Marianne was talking about in terms of the top-heavy management in the health system. And I realised that we have just become obsessed with targets. We have so many targets. We turn the NHS into the most micromanaged health system in the world. And, frankly, Stalin would be proud. And there is no reason to do that. It's nothing to do with having a state-funded system. We could do what we do in the education system, where we give heads a lot more autonomy. I think when it comes to certainly need to sort out the workforce things, but one final change, which is very connected to patient safety, actually. Marianne talked about primary care. It's now clear that it was a terrible mistake in 2004 to change the GP contract to get rid of the system where people had their own family doctor. And we changed it to a system where most people are attached to a GP surgery, and only in 10% of practices across the country have they kept the system of individual lists. And there was a study in Norway last year that showed that if you have the same doctor for a long time, you're 30% less likely to go to hospital and 25% less likely to die. Because if a doctor knows you and your family and your context, they're far less likely to get a diagnosis wrong. And so I think there's a big debate, should we change the NHS? I think there are some practical things that we could do that would make an enormous difference now without having to rip up a system that we've come to love and has come to be quintessentially British. And that's what I write about. And all profits, by the way, go to charity. I just say that because I've set up a patient safety charity that is doing one very, very specific thing. We're funding Imperial College to look into that 150 deaths a week figure and try and understand if it's accurate and try and get it more accurate. But I think I'll leave it there.
Right, I've got a couple of questions, and I'm coming to you in like 5 minutes, so ready yourself. I'm tempted to ask whether you think this government is a learning government, whether it learns from its mistakes.
I think they've been learning quickly.
They sort of make a lot of mistakes. But let me ask you a slightly different question. If you were Therese Coffey, what would you be doing?
First of all, of the cabinet, I was actually very pleased that Therese Coffey got this job because she's a softly spoken person and she's a listener, and I think I think that of the people that Liz Truss could have chosen, I was actually happy that she chose Therese. What would I do? I think you have to follow. I would listen to Marianne. That's what I'd do. And Marianne said something very important just then. She said, when you're faced with what looks like an overwhelming problem, choose to fix the single thing that could make the biggest difference.
Okay, well, I'm see if I can get a more specific answer
I'm
out of you.
I'm about to do that.
Okay,
and that is workforce. We've got to stop this system, which means that we are just not training enough doctors and nurses for the future, and that the doctors and nurses we have are leaving. I'll tell you something really rather extraordinary. We now spend the 5th highest amongst the OECD richer countries, the 38 richest countries in the world. We are the 5th highest in terms of the proportion of GDP that we spend on health. And yet, they have 20% more doctors per head in France and 60% more doctors per head in Germany, because we've just not sorted out a system where we train enough. Now, in my own defence, because I know your question will be, why didn't you do this, Jeremy? I did set up 6 new medical schools, but the truth is that decision rather proves my point, because the first doctors from those medical schools will enter the NHS workforce in 2024. Because it takes 7 years to train a doctor. And that's why we need a system where whichever party's in power, whoever the health secretary is, whoever the chancellor is, we're always training enough doctors for the future. And that's where I would start if I was Therese Coffey.
Yeah. Do you think you'd be in the job very long if you said to the Prime Minister, that's what I'm going to do? I'm going to make things easier for the person who's doing my job in 6 years' time.
Well, it's not. It would make things easier for her too. Because doctors are very realistic. Every single thing that goes wrong in the NHS, people are telling her it's the workforce. And no one expects this to be solved by Monday morning, but they want to know there's a proper long-term plan in place. And if she put that in place, she would be sending a message to the young, newly qualified doctors and nurses. Look, it's really tough out there on the front line, but it's not always going to be like this. There is hope. And I think that's in short supply at the moment, so I think it would make a very big difference.
Okay, let me ask my one question, and I'm absolutely going to come to your questions. Almost every week, sometimes every day it appears, there is a talking head in the Telegraph or the Spectator or others saying the game's up for the NHS and we need to rethink again, and the time has come, and etc. etc. For the first time, I as you know, am not a great believer in, I don't believe the great conspiracy theory that the Tories had it in for the NHS. But I get for the first time that there's actually a significant number of people within the Conservative Party close to power, if not necessarily in power, who would countenance, looking at social insurance models and doing things differently. There are lots of people like you, I know, who would very much resist that. But do you see a change in emphasis that those people are growing in influence?
The game is not up for the NHS. Absolutely not. We are all going to spend more on our health and care. If you're in America, you're going to spend more through your insurance premiums, which are going to go up like our car insurance premiums have gone up here. If you're in Holland or Germany, you're going to spend more through your social insurance premiums. If you're in Britain, Ireland or New Zealand, you're going to spend more through your taxes. And the issue is not fundamentally about the way we fund it. Let me finish, let me answer the question. You could have said the same thing about state education in the 1970s and 80s. When I went to Charterhouse in the 1980s, middle-class families said, if you can possibly afford it, don't go to state education, go private. They don't say that now, because state schools have been transformed over the last few decades. Middle-class families, if they've got an outstanding Ofsted school in their area, they're thrilled to send their children there. And we've done that because we treat our schools very differently. If we said to the Education Secretary, you've got a target to get 124,000 physics A-level passes next summer, and you'll lose your job if you don't, then that Education Secretary would hire bureaucrats to, at a local level, at a regional level, at a national level, they'd be on the phone to every secondary school in the country. How many have you got going in for your A-levels? And couldn't you just bump it up a little bit? Because, what about take a few people off this subject? In fact, you'd be recreating NHS England for education. NHS England has 22,000 people who do exactly that for Marianne and her colleagues in the NHS. We've learnt in education. It's not perfect. lots of things we need to improve in education, but standards are getting higher, and we've learned that the way you do that is by empowering people on the ground. Heads basically get their budget, and they're told, you're going to have Ofsted, we're going to publish your exam results, but after that, it's broadly up to you. And that's what we have to learn to do if we want the NHS to take off.
Yeah, the question's short, because if the questions are short, then we can get as many possible in as possible. Right, gentleman there, lady there. Right, let's go. You go first, sir. Please say who you are, because it's always nice to know people's names.
So I'm Alastair McLellan. I'm a consultant neurosurgeon. It's an honour to be here and listen to you. And Marianne Griffiths knows me. I wanted to thank you for coming, and I'd like your warm reflections about what you've done since the Right Honourable Judge and all the improvements that you've made. I've read many parts of the report. And my question is about truthfulness, because, and I need to set the scene a little bit. I've heard the words rhetoric, positivity, change. Rhetoric is the art of persuasion, and another philosopher says persuasion of the foolish masses in the courts and councils. What people really love is truthfulness, and there's a saying that truthfulness is a foundation of all human virtue. My question to you is, how important is it for government to be truthful with the public, and for management and leaders of the NHS to be truthful with government? And the reason why I say that, very briefly, is this. You've hit a nail on the head, and you talk about scandals in Mid-South and others, and you talked about avoidable deaths. And as a surgeon, I can share with you that the patients who we love, they forgive you if you're truthful about your mistakes. What they do not forgive is lies.
Thank you very much. Very good point. Please.
My question...
Just say who you are, please.
I'm Susan Storrow. Am I on or not?
You are now. You are now. Very much so.
My question is about the proceeds from your book. I'm really interested in that work. So we know that during the pandemic, some groups of people were really adversely affected by the pandemic, particularly people from ethnic minorities, people with learning disabilities. That's been my whole career. It's been absolutely heartbreaking seeing people who can't speak, can't communicate, go into hospital with nobody. They haven't got a chance. I'm interested in whether the work that university does will do anything to redress the balance where of some groups of people being at an inherent disadvantage. People with learning disabilities, the average class down at the moment is 59. It's pitiful. It's awful. So what will those proceeds of that book do to redress that issue, as opposed to the sort of system issues that mean that people are harmed?
Okay, thank you very much. You just said, I think the terrible outcomes for people with learning disabilities is, to a certain extent, a system issue. Jeremy, why don't you answer that question directly first of all, and then we'll come on to the truth question, but that's a very specific question, so why is that?
There's a whole chapter in the book, actually, about the terrible care we give to people with learning disabilities. There's a terrible story about a young man called Connor Sparrowhawk who died because he had an epileptic seizure in a bath when he should have been supervised.
I've been at Care and Treatment Review with somebody in a specialist privately run hospital, and that night she died. I'm sure you know who she is.
Yes.
If only it was only Connor.
So the answer is the research is being led by Lord Darcy, who was a former Labour health minister, actually, under Gordon Brown, but who's a big expert in patient safety, and he's trying to look at all those issues. So yes, he's looking at every preventable, avoidable death, and you're absolutely right. There are certain groups who are disproportionately affected, as we saw in the pandemic. So yes.
Let's come to truth. Very good question, if I may say. I was on the way down here, was writing an editorial, and it was precisely on this point, which is the responsibility of, one of your points, was the responsibility of local trust leaders to tell their local politicians exactly what was going on, in the hope that those local politicians could carry the message higher. You've got your MP here. Tell us a bit about how you tackled that, how you spoke truth to power, either through the NHS England structures or directly to local MPs and others.
So again, it depends. So there's a slight difference in a pandemic, which I'll come to. But I think it's actually the truth. We do get things wrong in hospital. There sometimes is harm, unfortunately, and people can make mistakes. And if you think about hospitals particularly, and I can talk about that, a lot of what you do in hospital is based on an initial judgment of maybe what the diagnosis is or whatever. And things can go wrong. I think what's important around that is that you acknowledge it. You don't chop people's heads off, actually, which I think is what you've said before, because I think that drives poor behaviour underground, and that you support the learning from that, and you actually genuinely try and, cascade that through all of your organisation and learn from it. I think where there are problems, I certainly have gone both to my board, where I might be worried about a service. It could be a workforce shortage, it could be a whole range of things that can happen. And I do believe I would have been as really honest with my board as I would be with anybody else about the risks that we were carrying in a particular service. And in the pandemic, I would say to you, Alastair, and I do know that my local MP would have known that, I did regular briefings of our board on a weekly basis and of our MPs on, not weekly, but probably fortnightly, 3-week basis about the risks that we were carrying during that period. And exactly as somebody has said before, sometimes the disproportionate effect of those risks that have on different people as well. So we absolutely did talk about that. And I think that would be captured in board reports and board minutes and board everything. So you do that. There's an interesting question about truth. So I just say this because what I've learned also in hospitals, that you can have a very compelling story from somebody. You do need to triangulate it. So people have different truths sometimes, and you do sometimes need support to help you actually come to the real story, in a sense. And I think you've also got to be open to seeking help when I think you need it from those perspectives. And certainly we've done that quite a lot as well.
Thank you. One of the gentleman's other points, Jeremy, was about how honest governments should be with the public. And you'll know, because you'll read those messages again and again, you get the various representative bodies saying what the government really needs to be is honest with the public. And when I hear that, I think, well, that's easier said than done, because public might not necessarily want to hear the truth, because the truth might be a little bit difficult to handle them. It's not very reassuring, the truth, often, and governments perfectly understandably want to reassure all the time. I also imagine that when you were in government and you were banging on about patient safety and about the levels of harm that were happening in hospitals, as they happen in hospitals over the world, that some of your senior colleagues were telling you to shut up, Jeremy, going on about us harming people.
I don't think they were ever... I don't actually ever remember having been told not to talk about this as an issue. I think some people... I think I was the first health secretary who talked openly about these kind of stories, but I tried to do it in a tone which was supportive of the difficult situations faced by doctors, nurses, hospitals, but I didn't pull my punches. Let me give you an example of, I think the public are desperate for politicians to speak truthfully, but it isn't always easy. And it's not easy because of our system. So let me give you an example, practical example from my own time. I concluded that the NHS needed more money when I was health secretary, having talked to lots of people like Marianne and seeing the pressures we were having every single winter. Now, if I'd gone onto the radio and John Humphreys had said to me, the NHS is underfunded, isn't it? I don't remember if he asked me that exact question, but I'm sure you could probably find an example of me going, no, it's not. We're giving it record funding, we've got record doctors, record nurses, the kind of stuff health secretaries say. But what I then did was, it was my job, because you have to observe collective responsibility, and the position of the government was that the NHS had its budget and it had to live within that budget. But what I then did inside government, and Tim did the same often when it came to things he was trying to change at the Department for Education, was I lobbied, and I eventually persuaded Theresa May and Philip Hammond, with the help of Simon Stevens, to raise the health budget by £20 billion in 2018, which was a really substantial raise. And then it became the policy of the government to give the NHS a lot more money. Now, that process can be very difficult for the public to understand, because they would love politicians just to be honest about things. And I think the most important thing in politics is, in that situation, is never ever tell a lie. So, the sort of way you give a reply is you'd say, the NHS does have real financial pressure, and this is causing enormous difficulty for people like Marianne, and we're trying to do what we can. But don't say black is white. It is tricky. I've often thought, I spent most of this book saying we should have a no-blame culture in medicine. I've often thought, should we have it in politics? I don't think it would work, because I think we're a robust democracy, and actually the way you keep politicians like me and Tim humble is by the scrutiny from people like Alastair and the media and opposition parties. And so you're inevitably going to get people being a bit more careful with their words in that system. And I think it probably has more pluses than minuses to have the system we have. But it's not an easy call.
Lovely, right, okay. Lady at the back there, then a lady there, and then gentleman just in front of her. So, yeah, there we are. Yes, please.
Don't you think a way to help retain your noble, loyal, hard-working staff might be not to try to force them to take an unlawful, toxic, experimental jab that has been killing millions of people around the world and harming them? I personally know of 10 dead and 10 very severely injured by this toxic
thank you.
jab.
That's okay.
That's the start of my point. And
I think we've got your question. Thank you. We've got your question. Very clear one. No, lady behind first of all, and then gentleman in front.
I'd just like to ask if the NHS has a robustly supported whistleblowing process for doctors to highlight if there is a problem in their section.
Righty-ho. And gentleman in front, please. Just one front. There you go.
Hi. My name's Jeremy Gardner. I am a local councillor, but I'm not here with that hat on. Do you think that more decision-making should take place at a more local level, and that decision-making should involve local people and communities more? I'm not talking about a big reorganisation, but I've seen it done before. For example, in Tower Hamlets about 15 years ago, where I was working in the NHS under another great woman, chief executive, actually, who's just retired as well. But, for example, we would go down to the level of Stepney, get people in the room, GPs, pharmacists, who aren't usually in the same room, mental health, social care,
thanks,
community organisations.
I think we get the question. I'm keen to get other things.
Also to say, and led by public health in looking at what are the health issues facing local people and how we can help them. Okay.
Why don't you do whistleblowing? You do you do local involvement. I'll do vaccines. Because I'll be the one that gets shouted at then.
Okay. Whistleblowing. The answer is actually I set up a policy called the Freedom to Speak Up Guardians. Every hospital in the country now has a freedom to speak up guardian, which is someone who is not your line manager, who you can go to as a doctor and talk to about any concerns you have about the safety of care being delivered in your organisation. Marianne will know better than me, but not everything I did worked. I think that is actually one of the reforms that was pretty successful on the whole, and I've had generally pretty good reports about the Freedom to Speak Up programme, so I think that is an area of some progress.
Public and patient involvement in service change, as we would say in the jargon.
Well, I would say absolutely, and I know I've just noticed that the chairman of University Hospitals Sussex is here, and one of the things that the hospital has done is to genuinely actually set up a new process for patient involvement, because I don't think hospitals are very good at that normally at all. And I think there's a real focus on how we do that intelligently, with people, and the whole advocacy programme, which again is trying to target, particularly difficult to reach groups in how we do that and make it much more equitable and inclusive. So I do think there's a lot more to be done. And I do think it adds significant value, which is to respond to your question. And I'm really looking forward to seeing how that progresses, if I'm being honest. So, yeah, absolutely.
Medicines harm people. It's part of a patient safety issue that Jeremy has talked to. It's the nature of Western healthcare. Of course, they help many more people than they harm, and that goes for vaccines too. Please get your COVID booster as soon as you possibly can. Right, let's... lady here in the purple, and gentleman there with his hand up, wiggling his hands around there. Yep, please.
Good evening, everyone. My name is Margot Kelly, and I represent a local environment group. My question relates to how much is the NHS and the Health Minister able to relate and communicate with other ministers, because it's all integrated. And if you take, for example, air pollution, people living in tower blocks, and the mental health and the lung and other health issues that evolve from where they live, and the fact that very often it's the poor people who are put into the flats facing the polluted road. Can you communicate?
Yeah, very good. Very good question. Gentleman there, please.
Yes, my name is Peter Reeves, and I've been finance director for a couple of health authorities and primary care trusts in non-executive local hospital, and also finance director of Bupa Hospitals and Bupa Health Insurance. And one of the things that's astonished me is the amount of tolerance that's shown to poor performance in the NHS, not just patient safety, but there's an enormous amount of data around efficiency, just practical efficiency, production line efficiency, which simply isn't being used. And I take on, without making this too long, the example you've been given, Jeremy, of patient safety. Why on earth is a health secretary getting so involved? Wonderful job, though, you did on the subject. In every NHS hospital, you've got a chief executive and medical director earning more than the Prime Minister usually. You've got a regional tier on top, and that director and the medical director both earning more than the Prime Minister. And then you've got a chief executive of the NHS who's earning probably twice as much as a Prime Minister. What on earth are they doing? When the things going wrong in a hospital, enormous inefficiency, why on earth is a health secretary having to get involved? Surely you should be giving them a hard time and not letting them prattle on as last chief executive. You said about what a hard time he's having because you're not giving him enough money.
I do. Thank you very much, sir. Good question. I do feel the need to point out at this moment that the NHS has the lowest proportion of people in management positions in any Western health system. A little known fact, 4% of its workforce. But Marianne, the trouble with people like you and you, Chief, is that you're just not held to account enough. There are not enough people telling you where you're going wrong, and it's about time you were held properly to account.
Thank you for that. I feel I've been held to account quite a lot, actually. And I guess if I'm
Too much?
Well, at times. No, I do think we need to be accountable. I haven't got an issue, actually, with accountability. What I do have a little bit of an issue with, though, is, and I think that, again, we can get into a negative debate on this, is a little bit about manager bashing. Because I do think, we have a lot of clinical people who go into leadership and management roles because they really want to influence and make a difference for patients. That's their drivers, and that's what all of our drivers are, is to make a difference. I've got a clinical background. That's what makes me really passionate about patient care. Don't always get it right, of course. I would also say that I think, certainly up until the pandemic, we did actually deliver really well in our performance, as it happens. But sometimes, I'm not making an excuse, sometimes people's, where they are, kind of the environment they're in, the state of their estate, all sorts of things can make it more complicated to deliver. So I think, again, I think it's not bashing everybody. It's trying to understand some of the challenges and issues people have, and I think that's fair and just, and support them to try and do better, which I think is important. I have to ask you, Jeremy, why, did you want to bash people more, or why you did the patient safety bit? But, that would be my view.
You bashed a few people at the early point, didn't you? Matthew Kershaw, etc. And then you had a sort of change of mind, didn't you?
That's the narrative you like to put out, Alastair, and I'm afraid you and I are going to go to the grave disagreeing on that one.
The facts support my point of view. But anyway,
do they? I'm not sure they do. Were you listening to the phone calls I had with people like Matthew Kershaw? Anyway, I just, first of all, on Peter's point, it's actually really fundamental points. Why is it when you've got these very highly paid people that they aren't doing all these important things? And why is it that there's so much inefficiency? And technology is a very good example. Our hospital IT systems are woeful. Our GP IT systems are pretty good, but the hospital ones are woeful. And I think the reason is, but Marianne may correct me on this, but what I think happens is when you have really outstanding leadership teams in local hospitals, they do sort out the IT system, and we have some good ones. But for an average Joe chief executive, when they arrive, they're told at their district general hospital, your job is 4 hours A&E, 18-week waiting time targets, and sort it out next month. I want to see progress next month. And then you remove the flexibility and the autonomy to sort out those longer-term problems, like having efficient IT systems, which end up getting deprioritised. Barbara's question, it's the job of ministers to talk to other ministers in other departments to get them to agree to things that matter to your department. Now, prevention is better than cure, and we are the second fattest nation in Europe, and it really matters to us as a country, but it particularly matters to the NHS that we do something about our obesity problems. And I have to be honest, I think it's a shame if we start to soft pedal on the childhood obesity agenda, because I think it is something that it is really sad if we condemn a generation of children to unnecessary health problems when other countries have found much better ways to make sure that they don't grow up obese.
Having been a long time Jeremy Hunt studier, the word shame is like, it's an effing disgrace. I think I should say that. Right, come on, more questions. Gentleman there, lady there. Yeah. Another man with a fine beard, and lady there. Yes, sir.
Richard Shenton. It was mentioned earlier on in the talk that there is a problem with aftercare. At the start of the pandemic, the Nightingale hospitals were set up very successfully and very quickly. Would it be possible for either the Nightingale hospitals or something similar to be used as convalescent hospitals to help reduce the bed blocking problem that is plaguing all hospitals?
Okay, thank you very much. Good question. Lady there, please.
Yes, Jackie Whitford. I've worked with vulnerable families in the South East for 30 years, and I know that the health inequalities over this time have deepened. So the poor people, the most vulnerable families, their health is worse, their ability to access services harder, they die younger. And it seems to me, from my own personal experience with my family, that those who are able to advocate for themselves, find their way around the system, ask for a second opinion, be able to be an expert in their own particular medical problem, get the best treatment. Does your vision embrace how to reduce the existing widening health inequalities?
Okay, fine. You could. Which one, Jeremy? You go first. Which one would you do?
I'm going to just touch very briefly on both,
okay,
if I could. So this book is not about health inequalities. It's about medical error that happens when you're in the healthcare system. But we have this year passed the Health and Social Care Act, which is very, very much focused on tackling health inequalities because it's designed to bring in integrated care. And the point of integrated, that's a bit of jargon, but the point about integrated care is it's care that tries to treat people much earlier, to nip problems in the bud. And the most effective way of treating people earlier is to make sure they don't get the illness in the first place by tackling some of the issues that you raise. I mean, I mentioned obesity, but there are many other issues that need to be raised. It's a very important agenda, and I think the pandemic made us as a country look at ourselves in the mirror and ask ourselves just why it was that certain groups, disadvantaged groups, were suffering so much more badly than everyone else. On Richard's point about aftercare, in an emergency situation, the Nightingale solution was one of the most effective things I've ever seen, and it was brilliant work by the Army, actually, who came to the help of the NHS in its hour of need. But in normal times, the issue is the social care system, which is really the system that is supposed to be looking after those 13,000 patients, more than 10% of all NHS hospital beds at the moment, who shouldn't be in hospital. And it is crazy because a hospital bed costs about £400 to £500 a night, and a bed in a care home costs £100 to £200 a night. And if there's someone who just needs someone to call on them once a day, that might be £50 a day. So it's massively more expensive to park people in hospitals, which is what we do at the moment, which is why we won't solve the problems in the NHS unless we look at the social care system as well.
Just to build on that, because we did actually look at Nightingale's solutions when the rate of people remaining in hospital just got so high, and with our social care colleagues, and we did explore, for example, using hotels as potential step down, and we did look at Nightingale. The big constraint that we had in really making that happen was workforce. We simply did not have enough people in social care or domiciliary care or nurses that could actually go and support that. And in the end, that was the major constraint. But we did actually do a bit of a proper study on it to see what we could do. Just didn't work at the time.
Thank you. Right. Sir, you've got your hand up, and you, sir, at the front. So, one there. One halfway, that's right. You go first, sir.
No, Presley, I was going to ask about the effect of Brexit on workforce, but as a Pfizer victim, I think that the lady's question behind should have been answered.
Yes.
I think I did answer it.
Yeah,
I'm
you
sorry,
said
we're serious about
kills.
truth.
That's all you said, and that's very true. That's the truest thing that has been said on that stage tonight, that Western medicine kills. That's my question. Please listen to the gentleman.
Okay, yes, I'm trying to.
If we're serious about truth,
Thank you.
So what's your question, sir?
If we're serious about truth, then I think that the question of the vaccine should be answered.
Okay, well, I'll give the panelists the option to. I'll give the option to answer the question, sir.
Hi. Hi, my name's Don Fry. I work for MENCAP, a disability charity, but the NHS also saved my life, so I'm very grateful to it. I think people get the idea that the health and social care sectors should be brought together, so they're not separate. But the social care sector is currently running 165,000 vacancies, so simply the NHS completely understaffed. What one thing would you like to see to happen to bring the health and social care closer together and become more integrated?
Okay, fine. So, well, I leave it to either of you whether you want to address, add anything to my answer on the vaccines. But I'm sure you've got plenty to say about health and social care.
I think we just as you said, Alastair, we do need to be honest with people that the vaccines will have side effects on some people. But the point of these, the clinical studies, is to try and understand what proportion of people that will affect. And I think the evidence is, I think the World Health Organization say that vaccines, I can't remember how many millions of lives they've saved across the world, but okay.
You're sadly misinformed, Mr. Hunt.
Okay.
Stop being selfish.
We're a free country. We can have these debates, but the truth is, I believe the evidence shows that vaccines overwhelmingly save lives. And I want to make one point actually on this, because, Madam, you're entitled to your views, but I'm also, as a citizen, entitled to mine. I would not want my mother or father to go into a care home where they were being looked after by staff who hadn't been vaccinated. That is my choice.
On the point of integration, I think you asked what would be the one thing to do, and there are some really great initiatives around the country at the moment. So in Northumbria, they are looking at, for example, bringing in a really integrated domiciliary care service for people for discharge out of hospital. It's a great start. And certainly I know that University Hospitals Sussex is trying to look at that to see with social care and our other colleagues how we might actually do that to support. It's very focused, I have to say, on adult social care at the moment, needless to say. But it's a start about really trying to get a pathway that gets people out of hospital safely and quickly and allows them actually to get better at home.
Thank you very much. Right, last set of questions. I think there's one round here. And who else would like to go? Yes, and gentleman at the back in the green. So last two questions, please. Somebody who's around there? Yes, sir, go.
Thank you. My name's Robin Olivier. I'd just like to address the issue of the human face of the health service. Marianne mentioned quite rightly the kindness and compassion of medical staff. But it seems to me that nurses have become very much technicians. I know observations have to be done and recorded, but seem to know a time spent on computers and ticking boxes, no doubt chasing targets. And it seems to me that a lot of the time people just want someone to hold their hand and sit in and chat, and there doesn't always seem to be time to do that. Maybe there's a role there for volunteers to just come in and talk to people, help them do things like that, make phone calls, help me get ill sometimes. I just want to have that fits into the health service.
Thank you very much. Very good question, sir. You get the honour of the last question, sir.
Hello, my name's David Stafford, and I was just thinking it's something that Jeremy Hunt mentioned earlier about the sort of possible move to mainland Europe style social health insurance system. It's really to do with the funding, with the sustained funding for the NHS. Would something like that have to come in just to keep the level of funding as it needs more funding? Well, I'm not saying it very well, but I think
we get your point, sir, which is if the NHS is to get the money it needs, do we need to look at alternative funding routes to achieve that growth? Well, what about that? It seems a very pertinent question at the moment.
We spend a higher proportion of our GDP on health than any Scandinavian country, than the Netherlands, than Belgium, than Israel, than many countries that have social insurance systems. So I think there are things that we can learn from them. A lot of them, for example, have much better IT infrastructure in their healthcare provision than we have. But I don't think that is the pressing issue that is going to solve the problems we have. We made choices within the structures we currently have. And to answer Robin's question, for example, not giving people their own GP to go back to the same time. For example, depersonalising care by deliberately setting up systems where you see lots of different health professionals as a way of stopping too many personal relationships developing, which is sometimes done, I think, mistakenly to stop too much emotional connection from the point of view of healthcare workers. But I think that's part of the reason they go into that job and that profession. So I think we should do everything we can to rehumanise healthcare, because the NHS was set up to be the most humane healthcare system in the world. It still does an incredible job. One of the reasons why we have so many fewer administrators than other countries is because hospitals like Western Sussex don't have armies of people sending out invoices to people for their care the whole time. We dispensed with all of that, and people who use the NHS for all its failings. You know, my brother's been doing radiotherapy at the Marsden today, and as he battles cancer, the one thing he doesn't have to worry about is how much the whole thing's going to cost. And that is a wonderful thing which we should keep.
Right, Marianne, it's your manner, so you should get the last word.
Oh, goodness me. First of all, I've really enjoyed this evening and the level of debate, genuinely. I do want to finish, actually, on what the gentleman said about nursing, because I feel we've got, actually, the chief nurse of the University Hospitals Sussex sitting there in the back. And one of the things that I really believe, and going back to what you said, is about kindness and compassion in delivering our frontline care. And I do believe that huge effort is going in to make that more human, make it more felt. And I think exactly your point is right. We've got an army of volunteers that I just again want to take an opportunity to thank, who come in, you know, at meal times to help with feeding, to help sit with somebody, to hold people's hands. In the pandemic, we redeployed people who couldn't do the work that they were, employed to do at that point, who went to COVID ward to sit, to hold hands, to read messages, to be there when actually other people couldn't be there for their carers. And I just thought that was amazing. So it's just to, I think, end on that there is such a lot of good to build on. I am completely with Jeremy about a passion for a service, I have to say, a free health service at the point that you need it. And we've all had experiences. My brother lives in America, similar to you, where, you know, and I've been to visit some hospitals in America where people who need the hospitals, and the hospitals are half empty because they won't take Medicare and Medicaid. And actually, I think we should be really proud. It is the jewel in the crown of the UK, is our NHS.
Seems a fine point on which to end this evening. Thank you very much for coming along and listening to Jeremy and Marianne, a bit of me. Great questions, really good questions. Most of them really to the point and about the very significant issues the service faces at the moment. So, you know, I'm somebody who does this for a living. I've been doing it for 20 years, and it was a joy to hear a group of people who clearly think about healthcare, are interested in it, want it to succeed, but recognise its complex, its nature. So I've had a really good night, so thank you very much for that. But I think we should finish by once again thanking Jeremy and Marianne.